We will, we will be having a number of speakers today. First of all, will be Hanifa Matlangu, just speaking on behalf of the Rural Health Advocacy Project and launching the policy brief. And then I'd like to welcome our other two speakers, Aziza Rangunwala from Groundworks and Mafoko Pumani from Groundworks, but representing today the Public Health Association of South Africa. Thank you so much for being here and sharing your expertise with us. We're looking forward to having some meaningful discussion on this really important topic. Thank you so much for being here. Just a little bit of a intro as to how the session is going to work today. What we will be doing is I'll introduce each speaker. They will do their presentation, and thereafter there will be an opportunity for people to ask questions. You can do that through the Q&A button or through the chat, or if you would like to raise your hand and ask verbally, you can do that as well. So there's a number of platforms, and we'll keep an eye on all of those so we can get to as many of the questions as possible. So without further ado, welcome everybody, and let me introduce our first speaker. Hanifa Matlangu is a dedicated young woman pursuing a master's in epidemiology and biostats while working as a research intern at the Rural Health Advocacy Project. She is deeply passionate about raising awareness and advocating for mental health, gender-based violence, gender inequality, and rural health improvement. Thank you, Hanifa. You can take the floor and tell us all about this policy brief.
Hi again, everyone. My name is Hanifa Matlangu, and just want to put a face behind the name, and I'll stop sharing my video and start sharing my screen. Okay. Good afternoon, everyone. Once again, my name is Hanifa Matlangu, and I am a research intern at the Rural Health Advocacy Project. Thank you all for joining us as we launch our policy brief on strengthening primary health care for climate resilience and universal health coverage. So let us understand the problem at hand. As important as our health sector is, it contributes to climate change, and it would rank as the 5th largest carbon emitter if it were a country. This unfortunately contradicts the principle of first do no harm. Contributions from the health system are direct and indirect, with direct emissions being the use of fossil fuels, especially in hospitals, and the use of gases when treating patients. Indirect emissions account largely for the emissions of the health system. They include the use of electricity, manufacturing of medical products and devices, as well as the transportation within the health system, such as transporting medical supplies, patients, and staff. It is unfortunate that the effects of climate change fall over onto rural areas. Interestingly, the health system in high-income countries are the major contributors to climate change. Yet, low and middle-income countries are impacted the most by the effects of climate change. This occurs through the reduced agricultural production, whereby crop yields of staple food like maize and wheat are reduced. This puts people in rural areas at risk of facing food insecurity, as farming is likely to be their main food source. Natural disasters that occur can lead to the contamination of water bodies, and therefore leading to the high risk of developing diseases like cholera. Climate change in rural areas also leaves people with damaged homes and destroyed healthcare facilities. This therefore reduces the access to health, as damaged healthcare facilities leave people with no health services. This now calls for the reason to actually create awareness. This policy brief aims to do this by describing how the health system contributes to climate change and to look at how primary health care can be used to reduce this impact. Overall, our policy brief wants to advocate for the investment into primary health care, for climate change mitigation and adaptation, as well as the realization of universal health coverage. Climate change increases the need Climate change increases the need for primary healthcare as it poses a challenge to health in this 21st century. This is because climate change has led to increased outbreaks of food and waterborne diseases like cholera, as well as an increase in non-communicable diseases like heart diseases and mental conditions. The droughts that occur lead to the scarcity of water, leaving the little water available to become contaminated. This could result in people not practicing good hygiene and also no water for agricultural production. In events of extreme heat, outdoor workers like farmers face the risk of becoming dehydrated. This therefore increases the need and demand for primary health care, especially in rural areas where health services are already limited, and also because primary health care is their first point of contact and their first level of care. Climate change also has certain effects on the access to primary health care. Firstly, is the damaged infrastructure that occurs during floods or fires. Destroyed health facilities could leave the entire community without access to health services. An example of this is when floods occurred in Durban, some health facilities were closed for over a year. Secondly, traveling is disrupted when roads are destroyed. This also impacts the transportation of medications, workers, and patients. In situations where crossing a river is the only way to reach a health facility, that river being flooded means that the patient will not be accessing health services until the river clears up, leaving the person to have a health condition that is going to deteriorate even more. Finally, due to the increase of diseases, as mentioned, the burden of disease increases, meaning that more people will be needing health services, which means also that the demand of healthcare services will be increased. However, there are measures to mitigate the effect of climate change on primary healthcare. This can be done through building climate resilient infrastructure, which can also minimize the interruptions of weather conditions and ensure continuous access and availability of healthcare. By transitioning primary healthcare facilities to use renewable energy sources such as solar and wind, there can be backup when load shedding occurs. This also reduces the primary healthcare facilities' carbon emissions. Primary healthcare can be equipped to tackle the health issues caused by climate change. By strengthening primary healthcare services, there can be emergency plans put in place for when infectious diseases occur and also create opportunities for the training and retaining of staff for climate health issues. By using socio-ecological indicators, we can be alert and have early warnings for climate events and disease patterns. Policies that advocate for the multi-sectoral collaboration with primary healthcare are needed in actually tackling issues caused by climate change. An example of this is having the education department promote healthy diet and promote education that is towards climate-related issues. Lastly, primary healthcare promotes the relationship between communities and the health sector. So by involving communities in decisions related to climate crisis and health, we can achieve community empowerment. Primary healthcare can be used to reduce the health system contribution to climate change because it focuses more on preventive care. Primary healthcare is less resource intensive and produces less pollution. As it is the first level of care, by treating diseases at early stages, there is a reduced reliance on higher levels of care like hospitalization. With there being reduced reliance on higher levels of care and prevention of diseases at early stages, there can be a decrease in the need, in the demand for medical products needed in advanced processes like surgeries. This also reduces the need for transportation of medical products and devices. Primary healthcare also produces less waste, but the need for improved waste management processes remains. Primary healthcare can also be used to improve the universal health coverage, as it is the vehicle to achieving universal health coverage. Primary health care provides the opportunity to the access of a full range of services that are closer to the people. The World Health Organization estimates that 90% of the interventions of universal health coverage can be delivered through primary health care, ultimately providing a platform for us to progress towards the Sustainable Development Goals. Therefore, strengthening primary health care creates progress to universal health coverage and provide an opportunity for us to achieve optimal health for all. The overall recommendation of our policy brief is the investment into primary health care. Investing into primary health care can allow for the construction of primary healthcare facilities that can withstand extreme weather conditions. It can allow for primary healthcare facilities to transition to renewable resources. There can be a reduced need for higher levels of care through the increased practice of preventive care. Investing will also result in a reduction of medical waste produced in the health system and also lead to the promotion of health education because based on climate-related health risks. In conclusion, strengthened primary health care is needed to reduce the environmental impact of the health system. This will also lead to rural communities having better access to care as they also are hit hard by climate change issues. A primary health care that is improved will reduce the disruptions that happen in care as there will be a transition to renewable sources and climate resilient infrastructure. Our policy brief aims to address two objectives. One is to use primary health care as part of the solution to reducing the carbon footprint of the health system, and secondly, to improve universal health coverage. Thank you so much for listening throughout the presentation. And on the screen, if you want to read more on our policy brief, please do scan the QR code that's on your screen. Thank you so much.
Thanks, Hanifa, for that very interesting presentation. It is obviously such an important thing to have the budget available in the primary healthcare sector to be able to achieve these things. And yeah, really just to build trust in primary healthcare services again amongst the people, that the services are taking the health needs or taken care of. So yeah, thank you so much for that interesting presentation. I don't know if there's any questions or comments from the audience. I see that there is one question here from Anastasia. It's just, is there CPD points? No, there's no CPD points, unfortunately, for our presentation today. But I do think it is a meaningful discussion that we can engage in and hopefully have some positive outcomes. Is there any other questions or comments on this first presentation? As Hanifa said, if you would like to download the policy brief, you can just scan that QR code. All right, we have a question here. How is the impact of climate change seen or measured in PHC? Hanifa, I don't know if you want to tackle that.
So I don't mind. So actually, as mentioned, when natural disasters occur, which are mainly a result of climate change, this actually, you can have damaged infrastructures, including health facilities. And so, even if you have like the healthcare workers who are living in rural areas so that they can serve the community, when the roads are damaged and the healthcare facilities are damaged, it means that, access to to primary health care, which is mainly where, rural people who are living in rural areas access their care, that is actually affected. And by measuring this, we can look at, the extent to which, how many healthcare facilities are closed down because of that effect, how many people are not accessing, primary health care during the extreme heat, during the floods, and including staff as well. That's what I can say. If there's anything that you'd like to add, Sam, you're welcome.
Yeah, I mean, I definitely think that's something that would be important to measure. So, I mean, as Hanifa said, there's like very obvious things that you can see where people are not able to like access care, but there should be measures in place. And I think that one of the points in the policy brief is just about taking indicators from other sectors that can look at predicting of like weather phenomenons and that sort of thing that might be affecting access to care. Um, Also, one of the things that we say in the policy brief is that there should be like a standardized way of making facilities climate resilient. So there is a need to have those measures in place. I'm not sure that there are at the moment. And Aziza just now is going to talk on waste management so that she might be able to give some insights in terms of that as well. The second question is, do we have data on healthcare related emissions from a South African context? I don't think that we found any for in our literature search, but that doesn't mean that they're not there. I just don't think that they were accessible to us. But data is so important again. So yeah, I don't know, Aziza or Mafoko, do you know anything about like South African specific data for emissions?
Just shared a link on it. I don't think our data is complete for our emissions in South Africa for healthcare, but it's something we are working on. But there is a fact sheet on South Africa. That's the link I shared.
Awesome. Thank you so much. And then I see another question here. Also, when there are floods, water quality is affected. Oh, it's a comment. Diarrhea diseases as well. Absolutely. Yeah. I mean, obviously, when water gets affected, so many different things get affected. People are using that water for drinking water, also for hygiene practices, also for their crops that they're trying to grow. And so it'll just come out in so many ways. And one of them is definitely the increase of diarrheal diseases. So thank you for that comment. In terms of sharing the presentations, I will get back to you on that one. Dr. Myros, I will get back to you on that one. And then I don't know if there's any other questions for Hanifa before we move on to our next speaker. Okay. Thank you so much for your engagement with that presentation. Let's move on then to our next speaker, Aziza Rangwala. Just give me one moment. Okay. Aziza is a medical scientist and currently the Africa Regional Coordinator of the Global Green Healthy Hospitals Program based at Groundwork, an environmental justice organization, the African strategic partner of Healthcare Without Harm. Her previous role was in the public health sector, focusing on research, policy, and capacity building. She is also a Global Senior Atlantic Fellow for Health Equity. Aziza, we look forward to hearing what you have to say today. Please go ahead and take the floor.
Thanks, Sam. Good afternoon, everyone. If you're joining from our time zone. So like Sam mentioned, I currently coordinate a program called Global Green Healthy Hospitals for Africa. And I'll tell you more about it. My presentation today was going to zoom in on healthcare waste management and how that plays a role in climate resilient healthcare. So I'm not sure if you've seen this donut before. Oh, sorry, maybe didn't skip. So this donut is from Kate Raworth. It's called the Donut for the Anthropocene and Humanity's Compass in the 21st Century. So she speaks about what is necessary to have, to live a healthy life and to be in a healthy environment and on a livable planet. So the dark green circles show the social foundation and the ecological ceiling that encompasses a safe and just space for humanity, meaning we need enough water, food, health, education, income and work, peace and justice, political voice, social equity, gender equality, housing, networks, and also energy, also more importantly. But we also speak about the ecological ceiling, and a lot of these Earth's resources are not finite. And we've already had overshoot in a lot of things such as biodiversity loss, unprecedented climate change, and also land availability, land degradation, for example, as well. So, the best chance of enabling a life of dignity and opportunity for more than 10 billion people depends on sustaining these conditions, such as stable climate, clean air, protecting the ozone layer, as well as healthy oceans, thriving biodiversity. But now, the concurrent extent of the social shortfall and ecological overshoot means that it just shows all the deep inequalities that we're seeing globally, and it's because also of income and wealth, exposure to risk, gender, race, political power, both within and between countries. So climate change also results in increased frequency of events such as floods, droughts, and earthquakes. And these natural disasters, as mentioned earlier by Hanifa as well, leads to the contamination of our water sources, the disintegration of sewage systems, stagnation of bodies of water, and deterioration of hygiene conditions, which means it's a breeding ground for diseases such as diarrhea, cholera, and typhoid. And in addition to this, for healthy facilities, infrastructure and people's homes get damaged due to these natural disasters. And we saw the extent of this in KwaZulu-Natal in April 2022, where there was damage to infrastructure, and which is still not haven't been repaired. And healthcare facilities were even damaged, or access to these health services might also be damaged, where entire roads were washed away, for example. So, in the Global Green and Healthy Hospitals Network, we have these 10 goals that we work with. And the 10 goals that we work with are leadership, chemicals, waste, energy, water, transportation, food, pharmaceuticals, buildings, as well as purchasing, because a lot of healthcare's emissions also comes from scope 3 emissions, and a lot of purchasing is actually where the high carbon footprint lies. But one of the low hanging fruit that I'm going to explore further today is about waste. It's about us reducing, treating, and safely disposing of healthcare waste, in order to prioritize environmental health across all these different goals, because that's how we actually measure health systems resilience. So currently we have members, 124 members. So this is as of August. Actually, this is data from August 2024. We have 124 members in 11 countries, representing the interest of almost 6,000 hospitals and health facilities. And as you can see, most of our members are in South Africa. So zooming on to waste management. Historically, waste management was never prioritized the way it should have been to, prevent pollution and to protect environment and human health. And I just think historically, there's never been any form of industry that looks at protection of human health and the environment and prioritizing those two things. Now, the implementation of the Air Quality Act in 2004 led to decommissioning of on-site treatment of healthcare risk waste in South Africa. So some hospitals actually had incinerators, and a lot of these incinerators were not compliant to air quality standards, and they treated the healthcare risk waste on-site. Now, after this Air Quality Act was passed, and the decommissioning of on-site treatment, service providers were used that also used incineration, but incineration facilities were more central and only in certain provinces, meaning that there was transboundary movement of medical waste. Now, I'd like to mention here the polluter pays principle, which applies that all producers of waste are legally and financially responsible for the safe and environmentally sound disposal of the waste they produce. Now, beyond this, also what I mentioned about transboundary movement is we also have the proximity principle that recommends that treatment and disposal of hazardous waste takes place at the closest possible location to its source in order to minimize the risk involved in its transport. And in a lot of these studies on medical waste, there's also a lot of bias where we have more data on urban areas than we do have in rural areas. And I think when it comes to rural health and primary healthcare, this is an important integral part of healthcare waste is that there are treatment technologies available that are not as harmful to the environment. And we mentioned earlier that healthcare is responsible for 5% of global greenhouse gas emissions. So there's not just an opportunity to lower emissions, but also to realize the co-benefits. Because the elements of healthcare waste management include segregation, which is not always done accurately, waste classification, waste minimization, containerization, certain containers for certain types of waste, color coding, labeling, signage, handling, transport, storage. Sometimes needs refrigeration. Sometimes healthcare waste storage areas are required at health facilities, and not all health facilities have the infrastructure. And then finally, there's treatment and final disposal. And right now, the treatment that is used is incineration, which is the major source of air pollution. And over there, you can see a very big incinerator, which is a central incinerator in Gauteng. And then the smaller building is actually an on-site incinerator in a hospital in Zambia, where these high heat thermal processes operate at above 850 degrees Celsius and result in chemical and physical changes in the waste, which also result in the generation of products of incomplete combustions in the air emissions and the ash. And these high heat thermal processes are not just incineration, it also includes things like pyrolysis and gasification. So these are very old technologies currently still being used to treat healthcare waste. We've moved over, we live in the age of artificial intelligence, yet we are still using very old technologies when it comes to treating healthcare risk waste. Now, just to go a little bit more in about the air pollution and PM2 particulate matter 2.5, there's a lot of health effects, in your lungs, your heart, your blood, um, as well as mental health and your brain. So, why do we need to change and move away from incineration? I think that evidence is clear. After the pollutants from incineration in the facility is disposed of, the facility may be exposed directly through inhalation, through inhalation or indirectly through consumption of food or water contaminated by the pollutants from air to soil, your vegetation, as well as your water. Now, we need to look at how can we reduce generated healthcare risk waste as a possible cost saver. And I said possible cost saver probably quite lightly because it is actually one of the major cost drivers in the public healthcare system, second to litigation, is the treatment and the full treatment and management of healthcare risk waste. And healthcare risk waste is the major opportunity to reduce our carbon footprint, but also to look at better health outcomes. And when it comes to mitigation, the global south is not responsible for climate change. But when it comes to looking at how we can better our health outcomes, it is important to look at this as mitigation, but also co-benefits for adaptation. So we looked at one of our GHH members, we have service providers that actually use alternative treatment of waste, which is microwave and frictional heating technology. Some of them are on site, but this one is one of the big machines that can do way more than 500 kgs a day. And the healthcare waste is basically turns into a fluff that you cannot recognize as medical waste, completely disinfected using this type of technology, microwave and frictional heating technology. One of our other GHH members, George Hospital, they have actually applied this on-site and have an on-site medical treatment facility, meaning that their waste does not have to be transported all the way to Cape Town anymore. So it cut the carbon footprint by 99%, the volume of waste by 70%. They've seen huge savings in costs in this case, where they're actually treating their waste on site at George Hospital. And George Hospital is in a remote area, very far away from most medical treatment sites. This is another example at a private healthcare facility that belongs to Mediclinic Group, and they use a more chemical shredding technology, but it's also done on site. And licensing for this was granted by the Department of Environmental Affairs, Forestry, and Fisheries. So it's just about how healthcare waste currently is being managed. There are some instances where there is no healthcare waste management. We know about instances where there's open burning of healthcare waste in countries such as Kenya. There's, I think, over 160,000 open burning sites, including healthcare general waste as well. So these are all the different types of alternatives to looking at appointing a service provider and letting waste travel long distances in trucks, and increasing the risk to society. So just a few considerations I'd like to, pose is that, we're looking at how primary health care focuses on health promotion, disease prevention, treatment, rehabilitation, and palliative care. Now, when we're looking at primary health care, I always say that even though we're talking about global green healthy hospitals, um, I always say that health is actually outside of the hospital. Health actually is in the food we eat, in the air we breathe, and in the water we drink, and in just general our quality of life. So when we're looking at preventative care and early treatment, it means that primary health care has the potential to reduce hospitalizations and thus reduce the carbon footprint of the health system. Because on average, they say the waste per day, per bed per day is about 1.3 kgs per patient per bed per day. So if you have less patients in hospital beds, you mean it's reduced generation rates of healthcare risk waste, as well as the costs of managing your healthcare risk waste. So if we're looking at our health system, we're talking about climate justice and social justice issues in waste. It seems like a very far removed thing from when we're looking at a justice issue. But because of historical apartheid spatial planning, we see how rural areas are still suffering from the effects of segregation during apartheid, the less access to service delivery, and no investment in infrastructure. So when we're talking about a just transition, we're not only talking about moving away from fossil fuels, we're talking about a system change that is based on open democracy and a people-led process that addresses inequalities and injustices facing frontline communities. And the health sector plays a very important part in accelerating and investing into this type of system change that we're looking at. So just to conclude, I just want to say that what happens in the hospital environment ultimately has a negative impact on the natural and social environments, from the type of gloves used, to the water use of a facility, to if the facility has renewable energy, or whether the facility relies on a very polluting power generator, just to have a basic healthcare, or whether what type of anesthetic gas used in theaters. That also plays a big role, which type of anesthetic gas. And when we talk about sustainability more expensive, but we're already paying that cost, and the cost is human life, human health. So healthcare waste is not risk waste, is not just a health issue or an environmental issue. It's also a social impact on the livelihood of communities, exacerbating inequalities, and also looking at the sustainability. Um, so there's an urgent need to strengthen the primary healthcare to enhance the resilience of vulnerable communities while we're working towards universal health coverage that is deep from greenhouse gas emissions. And we know that South Africa is a significant emitter, because of our coal-fired power station. So I'm just going to end it at that, and welcoming questions, and also get in touch via email if you'd like to learn more about global green healthy hospitals. Thank you, Sam. Over to you.
Thank you, Ziza. Every time I hear this information, I just find it like really sobering. And it really does, as you say, bring across that like urgency, and it is a justice issue. Because a lot of the time, the people that are suffering the worst effects of this are the people that aren't contributing to it. And so it's almost like this thing of the unaffected are really, not really taking up the baton in terms of reducing carbon emissions. But yeah, sorry, that's my little emotive part. I do see there was one question here. Regarding the transboundary waste, I'm thinking cross-border, is that correct? And if so, how does international agreements and policy regulation speak to the control of climate and environmental impacts of the treatment of this waste? Or is this the purpose of the policy brief to update us on this? Is this
Okay,
for
so
Aziza?
I think I will just answer the first part. The policy brief mentions the reduction of waste as climate resilience and strengthening PHC, but I don't think it will update us on transboundary movement of waste. So there's international borders, but also each province has its own healthcare waste regulations in effect as well. And a lot of times, some provinces do not have treatment plants, or the service providers that are allocated do not have treatment plants in the province where the healthcare waste is generated, meaning long distance traveling. When it comes to international transboundary waste, we do see issues of waste colonialism that Gaia often writes about, which is not necessarily my specific expertise. But the transboundary waste that I mean is like where the waste is generated, like the waste travels sometimes from the Free State all the way to Limpopo, which is quite far, and the emissions from the transport of that is quite high. And this is specifically for healthcare waste.
So yeah. Thank you so much for that question, Aziza. Thank you for the answer. I also have a couple of questions that I would like to just ask. The one is, we were speaking about primary healthcare and how it can reduce like the amounts of waste that's generated compared to hospitals. When we were also reading for the policy brief, looking at literature, and that there were a couple of studies that showed that waste disposal policies at primary healthcare facilities are maybe not like where they should be as yet. And there is a need to often transport. They can't do it on site. They have to transport it to facilities that do have waste disposal facilities. So what would your suggestions, or what is your view on how we could improve that as well, so that we're not just generating less waste, but we also in the primary healthcare setting disposing it in a better way?
I think it comes down to compliance and actually having environmental health practitioners who act as waste officers as well, because waste officers sometimes are nurses who are actually overstretched. And we have an overstretched health workforce currently. So looking at our environmental health practitioners and in their scope of work, healthcare risk waste is very important. So I think from a district health point of view, primary healthcare facilities can benefit from district health services having a healthcare waste policy that comes with technical guidelines, as well as standard operating procedures of central waste storage areas, and also strict compliance for service providers who have to collect the waste, and adherence to waste collection as well. Especially now in summer when we see that, with heat, there's a lot of waste issues and pest issues in a lot of spaces.
Okay, thank you. I see there's a comment here. It's just good to have a known hospital KPI, average length of stay, correlate to pollution. So that's a comment from Dr. Bola. And then I think before we move on, Aziza, I do have one more question. If anybody else has any questions, please pop it in the chat now. But I have one more question. I was very interested in the new technologies that they have for waste disposal. And I know you were saying that it's one of the things that they could use as a cost saver in the long run. What is the initial outlay for instituting those things, putting those sort of facilities in place?
Yeah, so those need a high capital investment. So it really needs leadership to commit to it. So for the hospitals that have piloted this technology, there's about 6 of them in the Western Cape, and they fall under the Western Cape Department of Health's 110% Green Initiative, where they actually they also signed up to the UNFCCC Race to Zero. So looking at lowering the emissions. So the CEOs have invested in this system, but they've also shown a lot of cost reductions and spending on healthcare waste. So I think the cost benefit analysis shows a lot of benefit for these hospitals, especially where they're far away from business centers or treatment facilities. So it is a high capital investment, depending on which service provider, I mean, which brand you use or which company you use. But the technologies have been piloted and shown all the benefits. So I think they are expensive because we import them, but the costs do get recovered really soon.
And have you seen like sort of a growing will from leadership to implement these kind of technologies?
Yeah, there has been. It's just that in some cases there's lots of energy scarcity as well. Like we have certain power stations, like in Kenya, they say they want to implement the technology, but the power stations don't allow. But we're looking
Mm,
at also in WHO's attached working groups, looking at where medical equipment can actually use renewable energy at the load is not heavier, like voltage wise of what it needs. So I think there is pockets of interest. And yeah, I agree with Wendy that we need to move away from single-use products because single-use
mm,
products are also why healthcare has a high carbon footprint. And also your reliance on suppliers is increased a lot when you use single-use products versus when you use renewables.
mm. Yeah, that's a very good point as well. I don't know if there's any other questions for Aziza before we move on, but thank you so much. That's been so enlightening, and it's very exciting to know that there is progress in terms of technology that is more environmentally friendly. So thank you for sharing that with us today. Um, our next speaker, joining us today on behalf of PASA, is Mafoko Pomani. She is a public health professional and researcher with over 15 years of experience in the public health and development sectors in South Africa and Lesotho. She is currently working as an environmental health campaigner at Groundwork Friends of the Earth South Africa, where her focus is on climate and health, air pollution, and chemicals management. She is currently chair of the PASA Climate, Energy, and Health Special Interest Group and a Global Atlantic Fellow for Health Equity based at Takano. Mafoko, thank you so much for joining us, and please feel free to take the floor.
Thank you. Thank you, Samantha. Don't know if my please let me know once you can share, once you can see my screen.
We can't see it yet.
Might be having a technical difficulty. Apologies for that. Let me try again. I think my internet's a bit slow today. Try again. There we go. Can you see it now?
Yeah, we can see your screen now. It's not in presentation mode yet, but we can see the screen. There we go.
Great, fantastic. Thank you again, Samantha. Afternoon, everybody. As it's been said, my name is Mafoko Pomani, and I am based at Groundwork as an environmental health campaigner. But today I'll be representing PASA. I'm currently doing the Climate, Energy, and Health Special Interest Group. I know that PASA is an NGO or a not-for-profit organization that aims to promote health and well-being for all. And it really is a unique forum which supports, communities, professionals, and academic networks. And it provides leadership as well as a collective voice on issues of access to health and as a human right. So as the Climate, Energy, and Health Special Interest Group, we are a group of NGOs, researchers, academics, really wanting to advocate for a healthy energy policy. We believe that energy is a major public health issue and that human health is at the bottom of, climate change, especially looking at the just transition to renewable energy and how it will benefit public health for all. Our focus advocacy areas this year, we advocate for climate resilient the health sector. You've heard from Aziza about the global green and healthy hospitals. We advocate for the just transition to specifically center public health and a form of restorative justice, specifically for vulnerable communities in the Mpumalanga Highveld, where air pollution is rife due to the coal-fired power stations in that area. And we also, as a special interest group, are mobilizing support for our health sector, our National Department of Health, to endorse the COP28 declaration on climate and health. Aziza mentioned the ATTACH program, which is a WHO-led Alliance for Transformative Action on Climate and Health. The idea is for WHO member states to sign on and participate in different working groups that look at financing for health commitments, for climate resilient and sustainable low carbon health systems, supply chains, climate action and nutrition. So there are different working groups within ATTACH that member states are then expected to participate in advancing the ambition set by specifically COP26 to building resilient and sustainable health systems. I think from Hanifa's presentation, the vulnerabilities that are pre-existing are evident. And when we look at climate change and how we are already vulnerable due to socioeconomic status, issues related to food insecurity, poverty, but particularly our reliance on coal as a primary energy source. It currently deems us as one of the most carbon intensive countries in the world. And really the production of fossil fuel-based energy, Aziza mentioned this, creates pollutants that pose public health risks. And air pollution is responsible to approximately 7 million people, 7 million deaths every year globally. So in terms of the vulnerabilities, poverty I've mentioned, I think Hanifa also touched on, unequal or poor access to healthcare services. We know that we have high rates of non-communicable diseases, cardiovascular diseases, respiratory diseases, and that are then due to exacerbate the impacts of climate change. We know about the burden on the healthcare system. And the idea then is to have strategies to mitigate climate change by shifting to low carbon and clean sources of energy in order to then have those core benefits, the public health and climate core benefits. And South Africa, as we know, we're very good at, policy formulation. And so, since 2011, there's already been the National Climate Change Response White Paper, which set the vision, the country's vision to, responding to climate change, but also looking at issues that can lead to a low carbon economy and the just transition. And so there are quite a few already very comprehensive policy imperatives that exist to support our climate change response as well as the just transition. Specifically, the Presidential Climate Change Commission was established in 2020, and it advises on climate action and facilitates the move to a just and equitable transition towards a low carbon economy. And really, it also cements the idea that decarbonization is a national priority. And this commission then developed the Just Transition Framework, which estimates that we'll need a lot of money to move to realize this just transition. So 250 billion over the next 3 decades to transform the energy system. And I guess just to mention, our role as PASA, as the Climate, Energy and Health Special Interest Group, has been to encourage the health sector and specifically the Department of Health to participate at this national level in order to then center health in the just transition. We know that the Climate Change Act has recently been ratified by the president, and it obviously includes mitigation and adaptation actions. And there are a whole lot of other policy imperatives as well as legislation. The National Waste Management Strategy, Disaster Management Act, the National Environmental Management. And so these policies and acts are pre-existing. So there's need for then integration. And how do we ensure that primary healthcare then also becomes focused? The idea of health in all policies, and all of this requires, multi-sectorial discussions, but also multi-sectorial action, looking at different departments that are responsible for, food, transport, water, human settlements, and the like. So it definitely needs all hands on deck. I mentioned the policies that have been existing, specifically for the health sector, the National Climate Change and Health Adaptation Plan, which was established in 2014. And what I particularly liked about the plan is that it focuses on prevention, the idea of community participation, intersectoral cooperation and collaboration, like I've mentioned, the idea that there needs to be synergies between climate change adaptation and other public health initiatives, equity and evidence-based planning. We know, the inequity that already exists, especially when you're looking at rural communities, access to health, access to services in general. So the idea that equity should be at the forefront, and really active participation from the health sector, civil society, as well as the private actors. There's now currently the latest draft, the Climate Change Adaptation Strategy for the health sector. And it also still then provides the roadmap for enhancing resilience and mitigating vulnerabilities. It looks at broadly these 9 strategic objectives, leadership and governance, as well as partnerships being the first, the need to finance climate change responses, as well as look into procurement, supply chain. How is this operating in terms of sustainability, but also looking at green procurement, human resources and labor. This is very important as well. Another strategic objective, spatial management of environmental determinants of health, health and climate research being very important, and really commending RHAP for the policy brief, and looking at climate resilient technologies as well as infrastructure. Aziz has kind of touched on this a little bit, as well as Hanifa, how there needs to be investment in infrastructure. The idea of data, integrated data and information management use, digitalization and early warning systems. And this is a really important area. I know Dr. Bolo talked about the average length of stay, and often you find that our data is not central, and it doesn't speak to each other. So, for example, at primary healthcare level, there needs to then be indicators that speak to climate change, but also look at air pollution. And often you'll find that they're using proxy indicators that then aren't very specific. But then how do these indicators then feed into the DHIS in order then to inform interventions that are fit for purpose? So broadly, these are the focus areas of the strategy, and lastly, monitoring and evaluation, as well as learning. And really it goes without saying, right, that the National Department of Health is a key player in integrating climate resilience into healthcare planning, as well as service delivery, right? So the idea of policy integration, ensuring that policies are responsive to emerging health risks associated with climate conditions. We've already talked about infrastructure development, at how this is also a key area. Workforce development. Do our health professionals have the knowledge and skills that speak to their ability to respond effectively in disaster, in climate or extreme weather events? Are they being capacitated? And so I think this is also a very important area. I think it's important to then, not to reinvent the wheel, but to leverage on existing primary healthcare programs in looking at climate change responses from a health sector perspective, right? Do these adaptation strategies integrate into existing programs, right? Communicable disease responses, non-communicable diseases, environmental health promotion and nutrition. We know that there's a school health program already, and how are we integrating climate change response or climate change resilience into already existing programs? The commitment to primary health care is not a new endeavor. When you look back at the Alma Ata Declaration and its sort of focus on primary health care being the issue, and the idea of then responding to equity and universal health coverage has already been mentioned. I think more importantly, I've just mentioned, the idea to invest in a well-informed health workforce, the knowledge and skills needed for climate resilient healthcare practices. Are our health professionals able to respond to the changing disease patterns that, they're going to be seeing? What kind of training is then invested in keeping them up to date? But how vigilant are health professionals to also take initiative and demand the need for better capacitation, better training, access to resources? And so as part of our partnership with Healthcare Without Harm and PASA, we have developed some guidance documents for health professionals. And really, they cover all the different areas that speak to climate change. And at the end of every chapter, it kind of outlines, what can health professionals do? What can the health system do? So I'll put the link in the chat when we're done to access these various materials. An issue that's always been close to my heart, health activism is necessary in order to adequately employ strategies to mitigate and adapt the climate crisis. And so the idea of first doing no harm, but also ensuring that people are living in an environment that is not harmful to their health. But as health professionals, the trusted voice, the solidarity, the expertise is required to then support communities that are going to be accessing care, communities that are going to be impacted by various climate disasters. So it really requires the interest and commitment and really that call to duty for health professionals to then, take interest, but also then act for the climate. And just to end off, basic things, this guidance document also kind of outlines, what actions can public health professionals take, right? At a personal level, it's being conscious around, how are we using energy? Being energy efficient at home, in your office, using energy efficient appliances. These are some of the things that often we overlook, and how all of these then contribute to the bigger picture. We've just talked about, effective waste management practices, right? This can also happen at an individual household level, not just in a health facility. So, segregation and composting, right? reducing the use of plastic in all forms. This has already been mentioned. Placing climate change educational material, brochures, and the like, to be visible in areas where patients are, in health facilities, in consulting rooms. Looking for appropriate ways to incorporate climate change and health into patient education materials, disease management plans and the like, medication sheets, speaking on the health impacts of climate change and strategies to address them. And I think broadly, we need health professionals lending their voice in the political discourse around energy and where we are as a country. It really needs the evidence and the influence to center health in the climate crisis, and really, being visible, being lending voice to the climate crisis. So writing op-eds and really capitalizing on current events. We're heading to COP29 currently. Last year at COP28, for the first time, there was the Health Day. And it's around really being visible in the negotiations and showing that, the human face of climate change, it will be, it is health, right? Yeah. So I'll end it there, Samantha. Thank you so much.
Thank you so much, Mafoko. Thank you so much for that insightful presentation. As you were talking, I was just thinking about how this has really got to be like a whole of society, a whole of government thing. And I'm so excited that we could gather today and just look at like the health sector's part that we can play in mitigating climate change. So yeah, thank you so much for that. I really love the part where you're talking about integrating sort of the strategies to treat climate change health issues into existing platforms in primary healthcare. I think that's such a brilliant idea, just because, a lot of the time the healthcare workers at the coalface are so overwhelmed as it is with policies, and that just to have it integrated into existing policies and guidelines would be a really, really amazing way to go. I don't know if you have more to share on that, just in terms of how that could look.
I think, we've been engaging with the Nursing Association, so NOSA, to kind of also start getting the nurses to see their stake in climate change and the climate crisis. And I must say, often when you start talking about the just transition, right, to health professionals, it's like, it's Greek, it doesn't concern me. And I think it really starts there, to ensure that health professionals have the information around. Yes, it seems like it's a political issue, but at the end of the day, you're going to need to then know how to be innovative in terms of treatment plans that are given. But I think one practical issue is heat stress. So they currently, the Department of Health currently has heat guidelines, and how extreme heat is going to affect, already affecting maternal and child health, right? So that's something that is very close to, say, a clinician's heart, and they would be able to then relate that, heat stress is going to impact on maternal and child health, and I'm going to have to be cognizant of, where the mother or the expectant woman is coming from, the environment. And I think it really just goes back to focusing on environmental determinants of health, and how that's also very important, and then being able to diagnose and give direction in terms of, are you living close to a mine, the water's polluted, are you living, so it's that kind of relatability that health professionals need in order to then come to the party. Thank you.
So at present, it seems from your interactions with healthcare professionals that it's they're largely not seeing the urgency or how it relates to their practice as yet. The guidelines that you were talking about, you said you'd put a link in the chat. That would be great. We, as the Rural Health Advocacy Project, interact with the Rural Health Alliance, which is a number of healthcare professionals in rural areas, and I think that they would love to be able to access that. So yeah, thank you so much. I don't know if there are any other questions or comments. You can pop them in the chat, raise your hand, or put in the Q&A section. Let me just have a look over here. Okay. All right, I think that's all the questions for now. Thank you so much for your presentation, for joining us today. Thank you, Aziza, as well, for your time. It's really been really great just to come together and see what is it that the health sector can do to start, decreasing the contribution to climate change that we're having. And it's just good to have these discussions and look at positive ways forward, see the innovations that are happening, and think outside the box about solutions to these really weighty problems that we face. So thank you, ladies, for joining us today, and thank you to everybody who participated. We really appreciate you taking the time out. And yeah, please download the policy brief, have a look at the guidelines that Mafoko is sharing, and let's all join hands together to combat climate change. Have a wonderful day, everybody. And with that, we will close this webinar. Thank you so much.
Thank you.
Thanks, Sam. Bye, everyone.
Thank you. Bye, everyone.